Good evening, everyone. This is Professor Tasha, and I'm coming to you to do a recap of the things that we studied in class this week related to the endocrine system. Hopefully, you've had a good week and had a good time in clinical taking care of endocrine patients. I think maybe the most common patients that you've seen there are probably patients with diabetes mellitus. So that's not the purpose of this video, but we'll talk about that next week. So just so you know, your readings and your quiz for Bayshore is going to come from your Saunders book, depending on which Saunders book you have. The red book, which is edition 6, that's going to be chapter 45. And then you have the green book, which is edition 7, that's chapter 43. If you're not using either of those editions, you feel free to use your med surge text, and that is chapter 36. And so, whichever book you use, the content is the same. It's just that I like the Saunders book because the wording is a little bit more easier to understand. And I found that students find that a little less intimidating. Also, with the Saunders book, you have your online resources where you have tons of NCLEX style questions that you can narrow down to endocrine topics. So I would highly suggest you do that as well if you haven't already done so. And if you're having problems with that, see me in class and I'll be able to show you how to get to those questions. So now to content that we talked about. So in class, we talked about a couple things. The first thing we talked about was SIADH and diabetes insipidus, which are direct opposites of each other. We found that the cause for those are tumors which rest on the pituitary gland. And so there's a couple things that we do to those tumors. Number one, we can either shrink them using hormone therapy. But if that's not effective, then we have to remove those tumors using the hypophycectomy and doing that through what we call the transfernodal route. And we did talk about post-op care for the patient who has had to undergo the hypophycectomy, which includes positioning, so semi-Fowler's positioning, also mouth rinses in for a couple of weeks after that. We also talked about post-op teaching that patient is not to blow the nose or brush the teeth for 2 weeks. And so this can be very frustrating for patients, but we need to let them know the importance of that. A couple of things we want to watch for post-op. Number one would be drainage from the nose or the ear, which could indicate CSF fluid drainage. And as we talked about in class, that's going to have like a sugary or glucose mixed in with the drainage. And so we need to test for that, okay? So now going on to the disorders that may happen as a result of that surgery, diabetes insipidus and SIADH. Okay, so diabetes insipidus. So what is the pathophysiology behind diabetes insipidus? So with diabetes insipidus, there is a lack of or too little ADH or anti-diuretic hormone produced. And because we have too little of that, that causes excessively dilute urine, which also results in a very low urine-specific gravity level. The opposite of that is SIADH, which results from too much anti-diuretic hormone, which results in urinary retention. Okay, and so we talked a little bit about what that patient would look like as well. Because you have urinary retention, of course, that patient is going to be very bloated. You're going to have fluid retention and also weight gain. We did talk about the lab values for each one of them. Diabetes insipidus, you're going to have, because there's going to be a problem with dehydration, you're going to have an elevated sodium level, okay? And so what does that mean for the patient? We want to restrict fluid and do what's called the fluid deprivation test. For SIADH, we want to also restrict fluid, but we want to make sure that we watch that sodium level, which is going to be the opposite. It's going to be very low, okay? And if we have a low sodium level, what does that mean? We need to be monitoring neural status closely, particularly monitoring for seizures, okay? The next diet disorder we talked about was hyperthyroidism. So hypothyroidism and hyperthyroidism, which are two opposites of each other. Hyperthyroidism, you're going to have the patient with very oily skin, weight loss, also heat extremes. And then for hypothyroidism, you're going to have weight gain. This patient is going to have intolerance to cold and also constipation. Okay, and so how do we diagnose that? Number one, signs and symptoms of each one, but we're also going to look at the thyroid panel, so your T3 and T4 levels. So if you have an elevation in T3, T4, that's going to be indicative of hyperthyroidism. If you have a reduction in T3, T4, that is going to be indicative of hypothyroidism. Okay, and so how we treat those is we're going to give doses of what we call Synthroid. Okay, it's called Synthroid or levothyroxine. That's the medication that we use. Right, patient teaching for that medication is we want to make sure that the patient takes the med as scheduled and usually in the mornings with no food. Okay, we're going to warn the patient not to stop those abruptly, because if they do, we can cause complications. So the complication for hyperthyroidism would be thyroid storm, and hypothyroidism would be myxedema. All right. And so depending on which one of those we have to treat that respectively. I don't want to get into all of that. We'll talk about that later in class, but those are the complications we watch out for. Also, we did talk about Addison's disease and also Cushing's disease, which are adrenal cortex disorders. Okay, Addison's disease, you're going to have a low serum cortisol level, which results in portal hypotension, so a very low blood pressure. Also, the individual is going to have what we call bronze-colored skin. Women may have hair on their face, so that's called hairism. Also, we're going to make sure that these individuals have doses of what we call glucocorticoids, because that level is going to be low. With Cushing's disorder is very rare. And so basically it's going to come from too much cortisol. And the result is the patient is going to be extremely bloated with what we call moon face. These individuals have a nursing disorder, or we assign a nursing disorder as body disturbed images, because it has the ability to distort the image. Again, there's moon face, and then the person has extremely truncal obesity. Also, they'll have problems with GI distress as well. So that's for Cushing's disease. All right. So those are the only disorders I want to get into, or the ones that you'll probably be quizzed on next week. So make sure you listen to this, know about the T4 levels, and just know the difference between the disorders. Remember, one is opposite of the other. Also, you want to make sure, really, really, really important. I know a lot of patients, or a lot of students sometimes mix up. What I've seen is diabetes insipidus. They mix that up with diabetes mellitus, which is totally different. So please don't make that error. We'll talk about diabetes mellitus this week coming up. So if you have any questions, concerns about anything I've talked about, send me over an email. I'll be happy to address those for you. Otherwise, I'll see you in class. Go ahead and like this video, share it with your friends, listen to it. I hope it's helpful for you. If I can be of more help for you, just let me know. Okay, so until next time, I will see you in class.